Well, good afternoon, everybody, and welcome, slightly delayed, welcome to the 22nd Parkinson's Academy webinar, the first for 2022. My name is Diga Hastus, and I'm the head of the Parkinson's Academy and the chair this afternoon. Before we start, I would like to express a huge thank you to Zambon UK Limited for sponsoring learning this afternoon. We'll be kicking off with Patsy Cotton and Robin Preclinical discussing pain management in Parkinson's. Can I ask you to use the Q&A function for any questions you have for our speakers this afternoon? We will take questions after each session. If you are unable to hear or see the presentations this afternoon, I suggest you log out and then log back in again. I think we're all used to doing that by now. Also, we are recording the Parkinson's Academy webinar, and this will be available to view on demand from our website next week. So, without any further delay from me, let me hand you over to Patsy to start this afternoon's session. Patsy.
Thank you all very much for joining us this afternoon, which I hope will prove a very interesting topic, which is quite topical at the moment from my practice. Okay, so what we're looking at here is, do people with Parkinson's actually get pain? Does pain particularly manifest itself in the end stage of Parkinson's? Is that when we particularly hear it, or is it? Can people with Parkinson's get abdominal pain? Can people with Parkinson's get hip pain? Is pain an unmotor symptom? Can pain impact on quality of life in people with Parkinson's? And is it up to 50% of people who actually experience pain with Parkinson's? Okay, so do you get pain in Parkinson's? So that's what we're here to explore today. And from the literature review and the papers, one can say that pain is really underestimated in people with Parkinson's and very frequently goes unnoticed. We have several types of pain that people experience in Parkinson's, and I think people in the audience will be quite experienced in hearing this. So some people will call it musculoskeletal pain. Some people will actually say that they get a pain up the back of their neck and across their shoulders as a coat and hanger pain. We recognize this very much in multisystem atrophy, but we also see it very much in Parkinson's. And one of the symptoms is that of low blood pressure, postural hypotension. And one easy way to see if this is right is just ask somebody to lie down, because then the pain does seem to go away. We have people who describe it as very fluctuating pain. And this fluctuating pain is very related to their Parkinson's symptoms and also to their medication. We have patients who tell us about chronic pain. We have people who tell us about the chronic pain, particularly when they're constipated, they get really bad abdominal pain, and also people who tell us about bladder pain as well. We frequently hear this. People who also tell us about pain at night, people who tell us about mouth pain, and indeed this burning mouth syndrome. We have people who tell us about swelling pain, and we know that people sometimes who might be on dopamine agonists get swelling associated with it, but this can also cause them pain. We've had people telling us about shooting pain and a painful prickly sensation. We have people telling us about pins and needles, aching pain, burning pain, numbness, tightness, twisting, and writhing movement pain. So just to walk through some of these symptoms that we hear people express, and to answer the question, does end-stage Parkinson's cause pain? And this is something that I think we're very aware of, and we're particularly aware of this, as I've noted here, is with withdrawal of medications, that people can become quite rigid and also perhaps maybe experience dystonic pain. But I would like to bring to your attention that the study that I was looking at, we're looking at 85% was recorded that people with Parkinson's at the end of life experience pain. And I think that's quite significant and also quite worrying to think that some of our people with Parkinson's are experiencing pain in the end of their lives. So really, really undiagnosed and undetected. The most common one that we know, as I mentioned, is that the rigidity and the dystonic pain, off-period pain. Once again, end-of-life care, perhaps maybe medications have changed, and more importantly, maybe people aren't getting their medication, their levodopa on the end-of-life care that they should be getting, and as we all know, if somebody's know by mouth, perhaps maybe it's not being correctly delivered. And of course, the medication on time, every time, particularly in our end-of-life care. Okay, so is pain an unmotor symptom? Again, it's something that is not very much acknowledged, and we know it as a non-motor symptom, and sometimes we don't recognize this as something that might even predate a diagnosis of Parkinson's. Okay, so the presence of pain in people with Parkinson's. So again, looking at a literature review, it varies tremendously. So anywhere between 40% and 85%, and everywhere in between. It's very, very varied, isn't it? It's so undetected, and also fluctuates so much. And I think also when we look at prevalence of pain in people with Parkinson's, one thing to bring to mind as well is that, just because somebody has Parkinson's, it doesn't stop them getting lots of other things as well. So therefore, one has to be very careful when you're looking at somebody who's describing pain in Parkinson's, that we're not missing something else, totally here. So pain is frequent, as I said, and it does fluctuate. It fluctuates with medications, it fluctuates with off times, and it also can fluctuate as people are peaking and troughing. And of course, getting their medication on time is most important. So to answer the starting questions, do you get pain in Parkinson's? Yes, you do. And interesting, some family members will say to me, gosh, I never knew that they might get pain. And it's like a really big surprise to them that on top of all the other symptoms that they might experience, they also get pain. And we'll come on to, in Robin's talk, how do we manage this pain? How do we manage this kind of multifactorial symptoms that people experience? So does end-stage Parkinson's cause pain? Well, yes, it certainly does. If up to 85% of people can experience pain. Can Parkinson's cause abdominal pain? And it certainly can indeed, particularly with people who have really bad constipation problems. Can it cause hip pain? Most definitely. We have the musculoskeletal pain. Is pain a non-motor problem? Most certainly, yes, it is. Can pain impact on quality of life? Well, yes, of course it can. And up to 50% of people experience pain in Parkinson's. So the answer is definitely yes. Now, I'm just going to talk you through this case study. When I was asked to do this talk on Parkinson's and management of pain in Parkinson's, I thought, do I really know an awful lot about it? And lo and behold, the next day, this lovely patient who I hadn't met before came into clinic and told me about his pain. I then asked him if he would write his case study for me of his journey with Parkinson's, to which he very kindly has done. So just to go through this, I'm just wondering, is there any way, I'm having difficulty reading the print on the slides, is there any way I can make it bigger? And if I'm having difficulty, perhaps the audience is too.
Fine. So the first point is that I was asked by my PD nurse specialist to write about my journey to diagnosis. My background is of a healthy, active person working as a GP with 30 years experience who enjoyed running, skiing and playing badminton. There was no past history of PD. Familial history of PD. I had some intermittent issues with cervical radiculopathy, probably due to poor posture and long periods of computer use in my work. These were usually managed with short episodes of physiotherapy. He's right-handed. Problems started in July 2017 with left shoulder pain and stiffness following a game of high-level badminton. It didn't settle with rest, and non-steroidals and subsequent physio and steroid shoulder injections didn't help either. The pain got worse with sleep disturbances, making him quite fatigued in the day with insomnia at night. I noticed that I was making a lot of spelling and typing mistakes with my left hand due to mild incoordination. He was tried on gabapentin and AMT, but they didn't help and caused severe drowsiness. Had an MRI of the shoulder in September with extended rotator cuff tear, MRI of neck, which showed C567 exit stenosis. And I had a cervical epidural steroid injection, which definitely helped my pain, but not in coordination of fatigue. Sounds very familiar. Patsy, sounds very familiar.
I was also aware of a very mild left-handed tremor and was very kindly seen by our local neurologist, who quite logically thought my symptoms were due to degenerative neck disease. I continued to work, but my pain and stiffness got worse, affecting all limbs with the left side being worse. In addition, I started to feel that my left leg would drag at times, with difficulty putting my left foot into a shoe. I got more and more exhausted and had many blood tests, which were all normal. And then one of my colleagues thought it could be a fibromyalgia and suggested a trial of sertraline, which didn't help. I also developed some constipation problems, which again were put down to stress and anxiety. And at this stage, this gentleman said to me as well, he said, I really thought I was losing the plot here, Patsy. He said, I just thought that this is it, what am I going to do next here? In July of 2018, so just to remind you now, this is a year after he first had his symptoms of pain, okay? He was asked to see the neurologist again, who very kindly saw him quickly. And he noticed a reduction of left arm swing on walking and left-sided rigidity with some bradykinesia and possibly slight facial expression was lost. He diagnosed early idiopathic Parkinson's disease and commenced him on a low dose of co-carbidopa, which quickly resolved my limb pains and helped my fatigue and my concentration. He said it was like a miracle. He just couldn't believe it. Currently, I remain well. His sleep disturbance is still intermittent, but he feels so much better. He takes his medication 3 times a day, and I will add here on time every time, and can almost tell when the next dose is due. His symptoms seem to reoccur. So when I saw him in clinic on this occasion, I haven't altered his medication at all at the moment because he really is doing quite well. Sensible person, he's going to get back in touch with me. And this is what I thought was so interesting, as well as his whole case study and his whole journey. I was aware of the typical Parkinson's disease symptoms, he told me, but never was aware that limb pain could be one. None of my GP colleagues were either. So I thought that, that was, very poignant to what we want to discuss here today. And that's questions, which we're happy to take now, or we can wait till the end.
Absolutely fine, Patsy. If we take questions after Robin's presentation, that'd be fantastic. Thank you very much, Patsy. Over to you, Robin.
Finally, okay, sorry about that, everybody. Delighted to be here to give a talk again for the Parkinson's Academy. My name is Robin Preclinical. I'm a consultant physician and geriatrician in the RUH in Bath and a faculty member of the Neurology Academy. And I'm talking to you today about pain in Parkinson's, and we've just had a great introduction to that. And I think that that last case showed the complexity of Parkinson's and the fact that actually premotor pain is something that we do need to think about in sort of retrospectively diagnosing Parkinson's. People who present with pain seems to be more, and if they've got sort of hyposmia, constipation, etc., and pain, it really does lend itself towards that diagnosis. So I think that is a really kind of a cautionary tale. So what is pain? I think we have to start there, because pain means different things to different people. And it's always a personal experience that's influenced to varying degrees by your biology, your psychology. So different people have different sort of pain thresholds and what it is you're doing. So social factors also, emotion plays a huge part in the way that people experience pain, and hypodopaminergic states also exacerbate your experience of pain because anxiety can go up, etc. Just to say that people will have heard of nociception, and pain and nociception are different phenomena. You can't necessarily infer pain just because you've got a stimulation of your nociceptors. But another important thing is that people learn how to experience pain as they live their life. So a child experiences pain much more differently to an adult. And I think it's always important to say that we need to respect people's perception of pain because it's so complex. Everybody experiences it differently. And I think that then provides a real challenging substrate to work out because everybody's different. And I think that's the wonder of Parkinson's, is that everybody's just so different. Pain serves as an adaptive role, so it stops you from doing things to make things worse, but it can have a massively adverse effect on your social and psychological well-being. And typically, non-motor symptoms often are the greatest detractors from quality of life, and pain is a big non-motor symptom. And often people describe pains verbally, but their inability to communicate sometimes doesn't mean they're not experiencing it. So it's sometimes you need to pay attention in different ways sometimes, particularly if a person is finding it difficult to express their discomfort. So the pain syndrome in Parkinson's disease, as was shown by Patsy's case, can often be pre-motor. So it comes before the diagnosis of motor Parkinson's disease. And to reiterate, there's estimates in different case series, depending on how you measure what pain is, that up to 85% of people with Parkinson's suffer with pain, which is an incredible amount. And actually, it's very under-recognized as such. But the literature around it is minimal. And really, the literature in pain, apart from a few papers going back to 1817 with the essay on the shaking palsy, which first mentioned it, there's only about 2008 where it first comes to the fore. 5 different types of pain have been described, which I will touch upon. And we know that dopamine is closely involved in people's appreciation of pain because there are lots of sort of thalamic, basal ganglia, cortical connections, and also the limbic system is involved. There's that emotion again. And so it makes it quite a complex thing to actually hone in on. Where do we actually focus our treatments? So just to reiterate again on Patsy's case, that preclinical Parkinson's disease with the constipation, depression, hyposmia, and REM sleep, pain is also there. And it also is a feature all the way across the Parkinson's journey. It does become more prevalent as the Parkinson's journey advances, but it can be present even before the diagnosis is made. But the process of pain is a complex one, and I'm not going to go into the neurochemistry and neuropathology of pain because you'll turn off. But there are 3 main stages. The first is pain sensitivity and the stimulation of your nociceptors. Secondly, those impulses then go from the periphery to the dorsal horn and the spinal cord via the peripheral nervous system, and then that's transmitted into the central nervous system, and you've got ascending and descending pathways. There's lots of stuff about C fibers and A delta and all kinds of things, but really those are the 3 main things to remember. So what makes you more likely to get pain in Parkinson's disease? There is a little bit of evidence that being female increases your chance of pain. The data around this is a little bit shaky, but it does seem that, that there's slightly more appreciation of pain in female Parkinson's sufferers than male. If you have early onset PD, you're more likely to have a pain presentation. And the longer you have pain, the more likely you are to develop it. And that's for a whole variety of reasons: posture change, motor challenge, dystonia, etc. If you have motor complications, again, they can be painful. And then if you have the apathy subtypes, anxiety subtypes, that normally changes people's perception of pain and make things more challenging for them. So they perceive pain more. The more non-motor symptoms that you have, the worse your pain syndrome tends to be. And if you have other comorbidities which can involve pain, then so much more likely to continue to experience pain in Parkinson's and have a heightened appreciation of that pain. We know that people with Parkinson's have an increased pain sensitivity. We know that their nociception threshold, their pain threshold, is reduced, and that is independent of disease stage. We know that Lewy bodies, which are instrumental in the neuropathology of Parkinson's, can impact on the parts of the brain responsible for emotional response, but also pain perception. And we know that hypodopaminergic states enhance the propagation of painful stimuli. And so you get a hypersensitivity effectively in the brains of people with Parkinson's disease. And we know that alongside that their analgesic neurotransmitters, so things like endorphins and metenkephalins, are lower, which then compounds the problem. And there's interesting studies about heat, and they did horrible things with lasers to people, noting that people with Parkinson's disease have lower pain thresholds. So there are, as Patsy alluded to, there are 5 chief types of pain in Parkinson's. I hope you can all read this. So musculoskeletal, that's the obvious one about, you know, if you hurt yourself, that's a musculoskeletal pain. You break your arm, that's musculoskeletal. And this is the most frequently reported type of pain in patients with Parkinson's disease. And that can be due to posture change. It can be due to all kinds of things. Frozen shoulders are common, aren't they? And that kind of type of pain. Neuropathic, which is sometimes a difficult pain to describe. People describe this sort of peripheral neuropathy, numbness, tingling, burning, and that's normally in a restricted distribution in a nerve root area, or in peripheral neuropathy in a sort of glove or stocking distribution. And this can, interestingly, worsen when the dopamine levels in the plasma go low. There's then this phenomena called central pain, where people find this is the pain syndrome of Parkinson's disease, which is really, really difficult to describe and likely arises because of all those factors I just mentioned about low levels of metenkephalin, etc. People find it very difficult to articulate what it is they are feeling, other than it's not normal and it's uncomfortable, but it can be aching, burning, cramping, panic, anxiety, tension, and it's described really as neuropathic pain, not restricted to the affected nerve root. And it's probably the best way of trying to describe it. And it's also been referred to in the literature as nociplastic pain, which is a very odd description, but nociplasticity. Other types of pain, which are more difficult still, are things like akathisic discomfort. So people who are very, very restless when they have low dopamine levels, that akathisic discomfort where they just have to move, and restless legs would be part of that, and this fluctuates with dopamine and responds to dopamine. Dystonia, you'll be familiar with off dystonia, where you get and people can see this in toes and ankle interning and that kind of thing, can be really violent actually, and can be very, very distressing for patients. So 5 different types of pain. And unfortunately, people don't just describe one of these pains. They often come multimodally and affect one another and worsen one another. So 5 types of pain: central, under-recognized, seldom treated, unfortunately, cause distress, and significant impact upon quality of life. I've said they're rarely responsive to dopaminergic therapies. Don't know really why I said that, because sometimes they can be very responsive to getting the dopamine right. Just about musculoskeletal pain is the most common, and it increases with age, usually felt around joints, typically arms and legs, tends to be localized, tends to be static, doesn't shoot, can be caused by cramps, rigidity, those kinds of things. Treatment normally is physiotherapy, exercise, and then anti-nociceptive analgesics, paracetamol, non-steroidal anti-inflammatories if they're tolerated, but be careful of these medications in older frail populations. And there's some evidence for something called Targanact, which is a combination of oxycodone and naloxone, which is useful because it's not constipatogenic, so it doesn't cause constipation in our patients, and we know how bad that can be for them. And I've just got a few pictures here of the way that you can see how people might develop pain. On the left, there's somebody with camptocormia, which is what bent spine effectively. They can stand up straight actually against a wall, and they can lie flat, but they get this bent spine. And you can see how that will affect your paraspinal and paravertebral muscles and cause quite a lot of discomfort, particularly with the weight of the head on the back of the neck. And that's just as evident in people that you would have seen with dropped neck syndrome, often poorly responsive to quite a lot of medication, actually doesn't normally respond to levodopa particularly well. And that can cause a lot of pain, referred pain up to the scalp and headache, and clearly leads to quite significant deterioration in quality of life for patients as well, because they can't look up. And then we've got Pisa syndrome on the right, which again is another paravertebral challenge that people can describe in certain phases of Parkinson's disease. So radicular or neuropathic pain is estimated to affect about 20% of people with Parkinson's disease, and it's normally in the territory of a nerve root, as I described. And it can be really, really quite painful. If you've come across people with diabetic neuropathy, which can just keep them up all night because it's so painful. So it's important to take good history about this. Dystonic pain, you can see that striatal toe and some interning of the ankle, really painful, and patients can be really distressed by dystonic pain. And they can be very simple, so it's just an inversion of the hallux, to these really complex combinations of dystonia, which can be quite difficult to treat. Things like apomorphine injections and sometimes botulinum toxin can be useful, but they can affect walking. And clearly, if you're walking on a dystonic limb, that can then cause you to have pain elsewhere because of the mitigating things that you do with your pelvis, etc. So peripheral neuropathy in patients with Parkinson's is relatively common, and patients with PD have a higher prevalence of what we refer to as symmetrical neuropathy. And it does increase with the higher doses of levodopa, and there's particular phenomena in people on duodopa, which is the intrajejunal levodopa-carbidopa intestinal gel infusion therapy, where the Cinemet gel is infused into the jejunum, which is exactly where B12 is absorbed, and that leads to a competition, if you like, which can then lead to peripheral neuropathy arising. So there is some evidence of using B12 injections alongside that. Remember also, Parkinson's is not the only game in town. Diabetes, thyroid, etc. You can diagnose alcoholism, actually can give rise to peripheral neuropathy. I always like putting this picture in slides because it's so brilliant, of William Gowers, who illustrated the essay on the shaking palsy in 1817. You can see pain in this guy's face, and no great surprise in terms of his postural challenge and stuff. And I think it's also to remind me that it's not just motor. We've got to be thinking more and more about non-motor challenge of our patients and the accrual of that. And just to say that non-motor wearing off is something that we really need to be aware of, because as dopamine levels drop, people don't necessarily get their motor symptoms of Parkinsonism back to any great degree, but they can get quite marked non-motor off periods. And I've listed lots there, and you can see number 3 is pain. And people can often describe really challenging pain that comes out of nowhere. And that can be abdominal, that can be chest, that can be limb pain, it can be all kinds of pain. But unless you take a thorough history of that, you won't necessarily attribute it to a non-motor off phenomena. Just about Priamo, this is a study by Baroni quite a while ago now, but this shows you that non-motor symptoms are common across the whole spectrum of Parkinson's disease. Number 2 on that graph, if you can't see it, is pain, showing that pain is more common as Parkinson's advances and the journey advances, but it's still very much present in early Parkinson's disease, and as we just talked about, pre-Parkinson's disease. And it's very clear that patients with non-motor symptoms and pain, again, number 2 on that graph, have a reduced quality of life than people who don't have pain. And there's no surprises there. But caution, please. There can be a tendency when we're looking to treat these things to layer multiple analgesics and dopaminergic therapies on top. And if there's limited response, we just keep putting more and more drugs in. And that can often happen because people will approach their general practitioner because the pain is a primary complaint and not linked to their Parkinson's disease. And therefore they get treated in different ways. So I had a recent patient that was referred to me from out of area who came to me with Parkinson's, but also was on 750 milligrams of pregabalin, 240 milligrams of codeine, zopiclone, and 5 milligrams of PRN diazepam to manage their pain. When I said to them, look, how is your pain? First of all, he was constipated, hypotensive, and really somnolent. No great surprise there because the anticholinergic burden of what we're giving him is so phenomenal, and he was still in pain. And that's because we're not getting to grips with what it is that is causing his pain. Now, quite a lot of this pain was because of emotion. It was like a cognitive emotional thing and his perception of pain. When we started to look at that, we then unlocked it. And actually, his dopaminergic control was also pretty poor. And we ended up putting this guy on an apomorphine infusion. And his pain was much, much better controlled because we had a much better control of his dopaminergic state. So when we approach pain, we have to be holistic every time. It's not just about, there's the cause of the pain, we'll treat that and it will go away. We have to be thinking about the stage of Parkinson's disease, what matters to the patient, so real shared decision-making, what the driver of the pain is and how it's arisen. And there's something called PQRST, which I will draw your attention to on the next slide about how you can approach pain in terms of taking a thorough history. We need to ensure that the dopaminergic profile is as good as it can be. Is there a lot of elements of wearing off and non-motor wearing off phenomena that we can smooth out? Because that sometimes is enough to help with pain. We need to remember that non-motor wearing off phenomena and think of other therapeutic intervention before layering on more medication. So therapy, OT, heat, massage, etc. And then we can trial low doses of nociceptive and neuropathic analgesics on top of that. But beware that often these conventional analgesic treatments often don't work quite as you might expect because of the complexity of the pain syndrome. And seek expert intervention, either from a movement disorder specialist or the pain clinic, and you can work closely with them. Palliative care sometimes can have some very novel approaches to pain, and often OT and cognitive behavioral therapy can also help people's pain perception. So PQRST, I'm not going to read it all out, but P is provocation, any relieving factors, any exacerbating factors, how much and what type, what does it feel like, and out of 10, how bad is it? Where is it located? Is it static? Does it radiate? Look at the severity. Does it fluctuate with time? Importantly, do we see, at the end of the day, that the pain gets worse when you stop taking your levodopa and we go into the evening? Is the pain suddenly coming to a crescendo then? Or is it much more intermittent and unpredictable? Just a quick case before finishing. 59-year-old lawyer, Parkinson's for 8 years. He's on Rapinol 14 milligrams in the morning and a bit of Stalevo, a bit of Rasagiline. So not an unconventional regime, is it? So he complains of crawling sensations in both legs from the later evening, which subsides by 8 o'clock in the morning, unable to get relief and just feels awful. And he gets some chest tightness at the same time. So he's got this really difficult to describe. He said, I can't really describe it. I just need to move my legs. But it's a crawling sensation and it's just awful and it just gets worse, but I just can't get any relief. And so I saw this patient after he'd been seen by a registrar colleague and been treated as restless legs because, this sounds a bit like restless legs or Ekbom syndrome, but I was unsure about whether that was the case. So Ekboms or restless legs is an overwhelming desire to move your legs, and it's often described as burning, itching, crawling, tension, difficult, nebulous symptoms. But movement in restless legs always leads to temporary relief. And that's how you define restless legs, and it's diurnal. So yes, it worsens through the night and improves towards the morning, but crucially, this guy can't get relief. And the reason he can't get relief is this is a non-motor wearing off phenomena. This is due to hypodopaminergic state, and he's got increased pain because he hasn't got enough dopamine. So what do? Give him a controlled release at bedtime, give him some reticotine, do something to optimize his dopaminergic thing, but don't give him loads of codeine or that kind of thing, because it's not that he needs. He needs an optimization of his dopaminergic strategy. So that's a relatively simple pain challenge, and there are lots of others where you have to be relatively strategic with how you address the pain syndrome. Is it mood? Does the patient need SSRI or sort of mirtazapine for anxiety alongside a dopaminergic regimen that's better suited to them? Do we need to be thinking about overlying some simple analgesia as well? But we have to always review, has it had a positive impact? And if it hasn't, we shouldn't just keep escalating the dose. We need to review and come back to where we need to get to. So there's lots of research going on in PD pain currently, and the ones that I would point to, the recent and ongoing research. So the RECOVER study is quite old now, but it had limited positive benefits for reticotine in pain. And that's probably because it enables a more continuous dopaminergic stimulation. So we reduce our risk of having those dopamine-related pain phenomena occurring. Sulfonamide, as you'll be aware of that, it has some effects on glutamate and also some effects on increasing, again, the on time without worsening dyskinesia. There has been some positive responses to that in terms of pain reduction. And opicapone, there's a current ongoing research with the OCEAN study about the use of opicapone in people who have painful wearing off. So as I've said, I'm coming to an end now, but treatment of central pain is difficult. And as I've said, opioids, gabapentin, carbamazepine, the newer stuff, it's not particularly effective on its own, but can play a part in trying to get to grips with people's pain. But I think maintenance of the on state is often very important as a starting place before drawing in other stuff. And just quickly, as a last slide, about sleep. I always focus on sleep because people spend, or sometimes don't spend, a third of their life asleep. And if you are chronically sleep deprived, your resilience to manage anything goes down. If you've been sleep deprived ever in your life, you will be able to kind of sympathize with that. But if you've got somebody who's chronically sleep deprived because of pain or for any reason, then their ability to manage that pain then reduces, and they exhibit higher pain scores generally. And we know that people with Parkinson's who have pain, without pain, and those with pain displayed longer sleep latencies, shorter sleep times, less time in REM, and they're more wakeful after their sleep onset, generally poorer sleep efficiency, which means that their resilience and their motor and non-motor function the next day will be less. And we know that people with chronic sleep deprivation have worsened cognition, they have lower mood, and all of that compromises them moving forward. So, you know, pain is really important. Sleep is incredibly important in maintaining patients' resilience moving forward. And that's where I will finish, just because I've probably gone over time, and I will stop sharing my slides and see if we have any questions. Sorry, that was a rattle through because it's a big area. I didn't touch upon burning mouth syndrome and the sort of nuances of pain in Parkinson's. But
we can do that in part 2, Robin, I'm sure, at some point. Thank you very much. Don't seem to have any questions at the moment. I'll let you consider, but we have a huge thank you from Lucy Dale to both of you. She's had to pop out, but she's going to come back and watch the rest of the recording later online. So thank you to both of you. And I think that was a really, really comprehensive run through pain in Parkinson's, very complicated. I have a question. I think both of you touched on the fact that people with Parkinson's don't really associate pain with Parkinson's. How do you start having that conversation with them? it can be quite hard, I think, both from a nurse's point of view and from the medic's point of view. So, Robin.
So I think it's important to dispel the widely held myth of patients that Parkinson's is all about tremor, because they, and not being able to walk very well. And very, very early on, by introducing, the questions that you ask them and why you're asking them from an early point in their disease stage. And I think it's about trying to portray Parkinson's as the syndrome that it is, rather than a collection of isolated symptoms, so that people recognize that actually this might be part of their Parkinson's, because quite a lot of people accrue lots of medications through their life with Parkinson's because they go to the GP with a complaint which is probably Parkinson's and not a primary complaint, and then they get more and more medications stacked up which are becoming less effective, and then the effects of polypharmacy, etc. So I normally just introduce, sometimes people tell me that they experience difficulties with pain, and that can be part of Parkinson's. And do you experience pain? And you can use NMS Quest and Parkinson's pain scales and King's Parkinson's pain scale, and there's all kinds of things that you can do to introduce questioning around it. But I think it's about sort of asking the right questions and asking a sort of a full and holistic view, and explaining to the patient that Parkinson's can affect all of these things, and we just want to make sure that we're covering all of it.
Hey, Patsy, anything from a nurse point of view to add?
I think that this whole talk today absolutely summarizes completely how complex Parkinson's is. It's as simple as that, isn't it? And I frequently say to people with Parkinson's, when they start to tell me about pain, and sometimes they might say, oh, well, this is something different, and I'll tell me about it. I've heard about pain from the top of the head to the tip of the toes and everywhere else in between. So, I think that we need to really listen to people with Parkinson's. That's the most important thing. And I think also what I find really helpful, and I don't know if you do, Robin, as well, is sometimes taking it like a 24-hour clock history from people. Start us off, right? What are you like when you first wake up in the morning? And if you do that, and it's almost a little bit like looking at a timeline along with their medication, so that, you can actually try to pinpoint some of this medication and some of the pain as well. And what makes it better, what makes it worse, all the questions that we would normally ask with pain, but also putting it into the package with Parkinson's.
Thank you, Patsy. Robin, I'm going to come back to you because somebody has mentioned burning mouth. I know we were going to touch on it at a later date, but it seems like Emily Pembroke has come across burning mouth twice in the last few weeks.
Okay, so
wants to help about treatment and management. So
yeah, so burning mouth syndrome is 5 times more common in people with Parkinson's disease, and there's various sort of opinions in the literature about why this occurs, and some people have actually attributed it to levodopa and high-dose levodopa treatments. It can be quite difficult, but sometimes agonists have been, there's some data about pramipexole use in treating burning mouth. It can be exceedingly difficult to treat, but generally reducing the levodopa burden and increasing the dopamine agonist, if you're able to, depending on the age and comorbidities and appropriateness for the patient. But often dopamine agonists, sometimes reticotine patches as well, can be useful. Sometimes using some neuropathic analgesics as well can help if the patient might tolerate them and the anticholinergic burden won't be too high. So sometimes pregabalin can be useful, but I think mainly it's that dopamine agonist and perhaps reduction of levodopa is normally better. More and more levodopa makes it worse, typically.
Perfect. Raj is asking about on-time dystonia, particularly abdominal muscles. Have you seen it? How do you treat it? Help, Robin, help.
Yeah, no, really, really good question. So on dystonia is, it depends where you look at the literature. Sometimes people just don't believe it occurs. I similarly, right, I've seen people who have what seems to be on related dystonia, when they have, when they're dyskinetic, they can also develop almost a dystonic dyskinesia, and dyspraxic breathing and abdominal muscle challenge can be part of that. I think trying to often the way I've dealt with mine is to try to ensure that people are staying within the therapeutic window as far as possible in terms of dopaminergic stimulation, and often continuous subcutaneous infusions of apomorphine have helped because you have better control over that. I think sometimes, although I'm not a huge advocate for it all the time, but PKGs can sometimes help in terms of looking at the overall motoric state of the patient going forward and actually getting a good kind of contemporaneous record of how they are otherwise, to try to work out whether it truly is on dystonia. But yeah, I think the phenomena exists, and I think sometimes you have to try to, in terms of the dopaminergic stimulation, it's about getting it just right, so you're not falling above and below the therapeutic window too often.
Perfect. One last question, and then we'll take a short break. So how can we differentiate PD pain from age-related pain? Oh, how long have you got?
Well, I think it's difficult, isn't it? Because people have osteoarthritis, etc. But I think musculoskeletal pain due to aging is often localized and static, as I mentioned. And what I would say is you can't differentiate them, because the very fact that your patient has Parkinson's disease will change their appreciation of the pain that they are experiencing. And so, yes, if you've got musculoskeletal pain, it's likely to respond to those nociceptive analgesics, paracetamol, oxycodone, codeine, whatever. But it's worthwhile making sure that your patient is dopaminergically as optimized as they can be to give them the best chance of moving well, to ensure that it's not exacerbating that pain. So you can't disentangle them because of all the complexities around how people with experience pain emotionally, etc. But if it's static and around a joint and it feels like, it looks like osteoarthritis of the knee, it probably is, but it's about how you then go about managing it. Sorry, that was a really garbled way.
No, that was perfect. Patsy, any last wise words before we go into a short break?
Just to put out there really about dystonic pain, and perhaps in the younger patient and person with Parkinson's, the use of deep brain stimulation.
Yeah, agreed. DBS is often a really good way of, if people have got like really disabling dystonia, DBS can often be very good. But there's often a wait for DBS, isn't there? And so therefore trying to optimize continuous dopaminergic stimulation, apomorphine, etc., is often the way that you might get more immediate control over the issue.
Lovely. Thank you very much, both of you. We'll take a very short break, and then we'll be back with Lucia Batsu and Silvia Rota. Thank you.